First, we're going to start with the knee passive mobilization. The first one is the femoropatellar joint caudal glide, which tells the patient to put in supine position with the legs extended and the therapist stands laterally to the patient. Our hand placement is one at the thenar eminence at the base of the patella, and the other one is placed over the first to stabilize. And like this, we will perform a caudal glide of the patella using this technique, and we will avoid applying pressure directly to the patella. The next one is a variation of the first one, but the patient with the treated knee flexed and the therapist stands laterally, and our hand placement is using a bimanual grip. Place the pads of both thumbs at the base of the patella, and like this we will perform a caudal translation of the patella with this grip, avoiding applying direct pressure on the patella. The next one is also a variation with the flexed knee, but at this time the patient in supine position and the therapist places their forearm under the posterior aspect of the thigh to be treated, and by elevating the forearm, knee flexion is achieved, and with the other hand at the base of the patella we will perform a caudal glide of the patella. The next mobilization is a femoropatellar joint cranial glide. The patient is positioned in supine position, but with the lower limbs extended. The therapist is laterally to the side mobilized, and the therapist places the open first web space of the hand at the top of the patella, performing a movement in a cranial direction of the patella. There is also a variation of this technique. The therapist modifies the patellar contact by using the pads of both thumbs on the inferior edge of the patella, performing the same cranial movement. It is also possible to perform the cranial caudal sequence at this kind of mobilization. The next one is a femoropatellar joint internal glide, which tells the patient to put in supine the cubitus with the lower limbs extended. The therapist stands laterally relative to the patella to be mobilized, and the pads of both thumbs are placed on the outer edge of the patella, while the fingers of both hands grasp the femur on one side and the tibia on the other. This frontal translation helps to tension the patellar retinacula. The next one is a femoropatellar joint external glide, which tells the patient to put in supine with the lower limbs extended and the therapist positioned laterally on the side opposite on the patella being mobilized, and we place the pads of both thumbs at the medial side of the patella. Use the fingers of both hands to stabilize the femoral and tibial segments. Glide the patella outward laterally. Also a variation of this technique, we use the heel of the hand to apply the mobilization. Additionally, an external tilt movement may be associated with the glide, and the patient is in the same position. The next one is a femorotibial joint anterior glide of the tibia relative to femur, the patient in a supine position with the hip and knee of the treated leg flexed, and the therapist sits at the midpoint of the table on the side of the knee to be mobilized, and both hands grasp the upper end of the tibia segment, hooking the fingers around the posterior aspect of this segment, and we will perform the mobilization. Next one is a femorotibial joint gliding in prone position. The patient lies in extended position with the hip extended and the knee to be mobilized in flexion, and the therapist positioned at the edge of the treatment table. Using a bimanual grip at the proximal end of the tibial segment, the therapist performs an anterior translation of the tibia relative to the femur. The next one is a femorotibial joint sliding through opposing forces femur tibia. The patient in supine with the hip and knee slightly flexed, and the therapist stands on the same side as the joint to be mobilized, one hand on the ventral surface of the distal femur and the other on the dorsal surface of the proximal tibia. Both hands apply forces in opposite directions. The next one is a femorotibial joint dorsal glide of tibia relative to femur. The patient in supine position with the hip and knee to be mobilized in flexion, and the foot resting on the table. The therapist is positioned on the same side to be mobilized. Sitting on the foot of the patient, the therapist places both hands on the anterior surface of the tibial segment. Both hands apply a force in a dorsal direction during the mobilization. The next one is a femorotibial joint gliding with knee in extension. The patient is positioned supine the cubitus with the knee and hip extended. The posterior surface of the lower end of the femur rests on a non-compressible cushion, and the therapist positioned laterally in relation of the patient holds the leg with both hands and applies a vertical force on the anterior superior surface of the leg. There is also a variation of this mobilization. One hand is placed on the heel and the other hand is placed on the anterior inferior surface of the femur. Opposing movements are then performed. Next, we're going to perform a femorotibial joint gliding through action of distal end. Patient in supine position with the hip and knees flexed at 90 degrees, and the therapist places one foot on the treatment table, position the anterior surface of the proximal thighs, and one hand supports the patient's thigh while the other applies a posteriorly directed force on the anterior surface of the patient's distal leg. Now we are going to perform a femorotibial joint flexion mobilization in sitting position. The patient, as I said, is seated and the therapist stands beside the patient. One hand grips the crural segment and the other hand holds the distal end of the tibial segment, and like that we'll perform the mobilization. The next one is also a flexion, but the patient is in prone position and the therapist stands next to the patient. One hand is placed on the posterior surface of the distal end of the thigh and the other hand holds the lower end of the tibial segment. By applying a force to the lower end of the tibia, we will perform the mobilization. So let's continue with a femorotibial joint internal rotation. The patient is supine position with the hip and knee flexed at 90 degrees, and the therapist is positioned next to the patient and decides to be mobilized. One hand is placed at the thigh to provide support, and the other hand is applying an internal rotation movement at the level of the ankle, and like that we'll perform the internal rotation mobilization. We can also perform an external rotation mobilization, patient in supine position, same as before, and the therapist is standing on the same side as the limb being treated, and the therapist stabilizes the thigh, and like that we'll perform the mobilization. The next mobilization we are going to perform is a valgus mobilization, patient in supine position, and the therapist is standing on the same side as the limb to be mobilized, and the therapist stabilizes the patient's ankle and foot in the axillary hollow, holding it firmly, and both hands grip the upper end of the tibial segment with one hand positioned at the lateral tibial joint line. At this point, we will perform the mobilization. The next one is a varus mobilization, patient in supine position with the leg of the edge of the table, and the therapist stands in front of the patient holding the limb between the inner side of the arm and the axillary fossa, and the internal hand moves along the joint line while the external hand supports the outer side of the joint, and like that we'll perform the mobilization in varus. And the last one is a tibiofibular joint anterior sliding mobilization with knee flexion. Patient is in supine lying with the hip and knee flexed, and the therapist sits facing the patient, placing their thigh over the patient's foot to stabilize it against the table. One hand grips the upper end of the tibia while the other holds the head of the fibula, and the movement involves pushing, and like that we'll perform the mobilization.